have other materials at the first sign-in table and membership materials, but there's a whole new system in place, and if you go to our league website, our Northeast Tennessee, there is a button to join or renew your membership, and if you're already a member, a button to go in and see all of your information and edit it as needed. This is like as of a few days ago, this whole thing was changed. So we're happy to have you here today. I am thrilled with the size of the crowd, given how awful the weather is. Thank you.
There we go.
Let's see. I believe next we have let me say quickly, our next meeting is March the 16th here, and we'll focus on the Constitution with a particular emphasis on checks and
Hey y'all, I'm also the one who will be delivering the cover next month on checks and balances, who does what in the federal government and who checks on them, make sure they do it right, etc. So do come back, we'll read some constitutional language. But for now, today I'm offering a quote from Jimmy Carter. Can you hear me okay? Okay, so today's quote is from President Jimmy Carter. And this can cover a lot of areas of our lives. He says, it's better to fail while striving for something wonderful, challenging, adventurous, and uncertain than to say, I don't want to try because I may not succeed completely. Make a note. Okay. Who's next? Renzi? Vice President?
Somebody walk off with the mouse. Okay, Becky, are you going to go over this or do you want me to?
You.
Okay. The League of Women Voters of the U.S. and the League of Women Voters of Tennessee have taken positions on reproductive health. And we want to briefly let you know what those are. As Gwen says, as individuals, you don't have to endorse every position the League has taken, but as a league, as an organization, these are the official positions of the League of Women Voters of the U.S. and Tennessee. So in the United States position is the delegates reaffirmed the belief in a woman's right to choose, the right to privacy, and delegates passed a resolution that the League was committed to fight for reproductive rights and justice, bodily autonomy, privacy, reproductive health, and access to contraception and abortion. So that's the U.S. position. In Tennessee, the position has two parts. One is to restore reproductive health care and access. In Tennessee, these positions by the state league often gave lead to our advocacy efforts during the legislative session. So the parts of that include decriminalizing the provision of abortion, legitimizing medically necessary care and interventions for those reasons, including teen care and private insurance covering the costs of reproductive health care. And the second part of the Tennessee League position is to expand access to reproductive health services through reforming Medicaid to cover low-income, non-disabled adults that currently are ineligible, and to increase state investment and equitable access to reproductive health care in Tennessee to medically underserved areas. All of this, I think, will tie into what you hear today. So our positions inform the kinds of things that you'll be getting information about. And there is a handout that gives you more detailed information. But rather than spending a lot of time on that, I want to move immediately into the presentation because we have some really qualified presenters who will advance our knowledge much more than it would be from going over their bios. So for most tables, there's a written handout that has information about their background, their current positions, their background, their qualifications. and I'll just refer you to that, okay?
I was going to offer a little more guidance on the impact on issues, which I would have done had it.
Okay.
Anyway, sorry.
That's okay. So I'm going to turn it over to Dr. Kate Beatty, who is an associate professor in the ETSU Department of Public Health in Health Services and Management and Policy. She has great expertise in public policy related to women's health, as well as many other things, and you can add anything you want about any qualifications. We're so grateful you're here.
Okay, thank you. Well, I'm really honored to be able to talk about this topic with you guys. It's actually one near and dear to my heart, and one that I've been doing research in for the past decade. So I am going to try to talk about something that I should probably give like a disclaimer, because since I've been doing this work, this is one of the areas where the policy landscape has been changing at like neck-breaking speed. And since 2022, we've seen it even go faster. And I don't know what will happen tomorrow or in 2 weeks, which is why this is so important for all of us to just be informed and keep our heads, informed, but also to not panic, because there is a lot that happens in executive orders, but there are also lots of lawyers who are involved in the process, and things go through court. So I keep telling myself that. So just take deep breaths as we go through this. There's just a lot going on. So that's my disclaimer. This could all change tomorrow. So I'm going to talk to you today about the current landscape and reproductive health in Tennessee. We're going to talk a little bit about some of the things that have happened at the national level, talk about some things that kind of change between administrations, and some long-standing laws that now seem to have more important impact than they did previously. So we're going to start with reproductive health care in Tennessee, talking about kind of three kind of areas that are of importance. So as a researcher, one of my areas of interest is access to care, specifically access when it comes to reproductive health. And so when we look at it from at the national level, about 19 million women, and this plays into your statement, of reproductive age are in need of publicly funded contraception. Okay, so that's the Medicaid piece. And 1.2 of those women live in a county with 0 health centers that provide the full range of methods. And so when we talk about the full range of methods, that means everything from IUDs, which are the most effective methods, and implants, to pills, patches, rings, cervical caps, diaphragms, all the methods. Because what's important about the full range is that women have the choice when they go into a clinic to receive the method that they want, or to receive no method if they don't want it. And so there are 1.2 million women in the country that live in a county where they cannot do that. So they would have to leave their county to receive those services. Now when we drill down to Tennessee, and we have links to these, and are you going to be able to share these out with
If it's okay with you, we will put a link in our newsletter, which you've now signed up for.
Yes, please do, because there's some great maps from Power to Decide and March of Dimes that are interactive, and you can look at your own county and look at these. So in Tennessee, we have over 400,000 women who live in contraceptive deserts. And 209,000 live in counties without access to any health centers that provide those methods. And one thing that, when we look at our region, that we can kind of be proud of is that this kind of darker purple means more access. And this is kind of like a statistical thing, but it's related to the proportion of women in the county. But a lot of our counties have 1 or 2, maybe 4 clinics. But a lot of those are in collaboration with academic partners like ETSU or nurse run clinics are in those counties who are providing those, which is a benefit that not every part of the state has. Not every part of the state has a place like ETSU that has an academic health science center that can kind of reach beyond just Washington County. So when we start to look at maternity care access, in the U.S., more than 2 million women of childbearing age live in maternity care deserts. And so in this map, the dark orange are the places in Tennessee that are maternity care deserts. And then the lighter orange are low access. We really don't have any of this yellow color, do we? Of moderate, but then we have full access, and that's really, we have this area in our region because we have a few health systems that have L&D hospitals. So we have a health system, and there's a health system that kind of go down that range right there. But what's important to know is that women living in maternity deserts have to travel 2.1 times further than women living in areas with maternity care access, which is a real big deal for any of us who have been pregnant or have had a family member pregnant. That's a long distance and can be really scary and has a big impact on the care you get. Women are more likely to have inductions if they live further away, because the doctors are worried that if they leave and something happens, they might not be able to come back. And those are kind of more expensive, and they're also might not be the choice of the woman to be induced, more C-sections. So it really changes the care the woman gets. All right. Now we're going to move from kind of the access to policy in Tennessee. And we're going to talk about abortion and the gag rule, which will play into some stuff that might be some stuff not as well. So I think we all know that with the Dobbs versus Jackson Supreme Court ruling, it essentially overturned Roe v. Wade, which made abortion the law of the land across the United States. And Tennessee, like many states, had what we called a trigger law. So they had on the books a law that if and when Roe v. Wade was overturned, that a law with a more restrictive abortion ban or abortion law would automatically, or within a certain number of days, months, would be put in place. And so this is a map of the United States from the end of 2024, December, that shows kind of what the landscape around abortion policy looks like across the nation. So Tennessee is one of 12 states with either a near or total or near total abortion ban. And so those are the red states. And so that's those 12 states. And you can see they're kind of, in public health, we're always looking at patterns and kind of distributions and clustering. So you can see where those cluster. And then kind of in the orangey colors, those are ones that have the next kind of dark orange are gestational limits between 6 and 12 weeks. And then the lighter orange is 18 to 22 weeks. So there's some sort of range in there that there's a limit there. The light blue is limits at or near viability, and the few really dark blue, it's kind of harder to see the difference in the blues, have no gestational limits, and that's 9 states. So you can see kind of the distribution and how your access now really depends on where you live. And that's something we talk about in public health a lot, that place matters. And so in 2022, all of a sudden, place mattered for this issue of abortion access. So in Tennessee, when our trigger law went into place, there were exceptions which were very gray. And one of the challenges that the conversations that are happening nationwide around law related to medical care is laws are often not made by medical professionals. So they don't always align. So there was legal action brought from women who were impacted by the abortion law. And the courts ruled that it was that the unclear exception to the abortion ban prevented women from getting medically necessary care. So because it was unclear, their providers did not provide them the care that they should have received under the exceptions. The wording was vague. What does medically necessary mean? How is that defined? Exceptions for the mother's life, and what is reasonable medical judgment? How is that defined? So that went through, but the recent clarifications to the policy are still vague. They hinge on pregnancy non-viability. And then the most recent kind of movement and abortion policy in Tennessee was that there was an attempt to expand our law to include rape, child rape, and incest, but it failed the House in 2024. So we can see that the black states have no exception for rape and incest in their laws, which includes Tennessee, Georgia, lots of our South. And then you see some blues and greens, and those are ones with certain kinds of exceptions, and then these other states that are kind of very light gray, they have exceptions. So we still have these kind of very near to total near bans in our state. Okay, the next thing I'm going to talk about is a law that you may or may not know about. It's called EMTALA, which is the Emergency Medical and Labor Emergency Medical and Labor Act. And it's essentially what we hear about, that anyone who goes to the emergency room gets care, right? You hear that? Anyone can go to the emergency room and they have to be seen. You hear this all the time.
Emergency medical treatment of
Active labor. Too many words. EMTALA is what we call it. This was passed by Reagan, so it's about 40 years old. And any hospital that receives federal funds for Medicaid have to screen and stabilize any person that comes through their doors, regardless of ability to pay. And part of that is providing medically necessary abortions. And this has been in place. Republican, Democrat, everybody is just, yes, that's available. Because when we talk about abortion, And a medically necessary abortion, we're talking about spontaneous abortion, a miscarriage. And when women come to the hospital for that, regardless of if they can pay, they are to receive that care. And there have been no batting of eyes until 2022, because we had Roe v. Wade as the law of the land. Once that was overturned, we have some states with near or total bans that were saying, well, we don't want to provide that care anymore. So this has been going through the courts. I believe it's through Nebraska. It went up to the Supreme Court. They decided not to hear it and let it continue to go through the courts. So this is just a short clip of the confirmation hearing of RFK Jr. around EMTALA. So that's just to give you a little bit of preference on what EMTALA is, because that's what they're going to be talking about.
Thank you for coming into my office and having the conversation that we did. I appreciate your passion, and you've spent years issues that matter to you. I appreciate that. I have a couple of questions, though I just need some clarification. Right now, there's a 40-year law that requires hospital ERs accepting payment from Medicare to to patients. So let's say a woman experiencing a life-threatening condition like a heart attack goes to the ER. As a lawyer, you would agree that that federal law protects her right to emergency care, correct?
Yes.
So now, a pregnant woman with life-threatening bleeding from an incomplete miscarriage goes to the ER. Let me rephrase that so you can hear. A pregnant woman with life-threatening bleeding from an incomplete miscarriage goes to the ER, and her doctor also determines that she needs an emergency abortion. But if she's in a state where abortion is banned, you agree also as an attorney that federal law protects her right to that emergency care, correct?
I don't know. The answer to that is I don't know.
Well, let me ask you this as an attorney. Doesn't federal law preempt state law?
The federal Constitution does. Not every federal law that preempts state laws. It could be unconstitutional. I'm just telling you I don't know.
I appreciate that. But what authority do you have over this as the director of HHS?
What authority do I have?
Yeah, to enforce the law.
In all regards.
Make sure that a hospital that receives payment from Medicare is ensuring that they're providing the necessary emergency care to save patients. It's actually the EMTALA law. So what authority as HHS director do you have with respect to EMTALA?
Understanding is that I have budgetary power and pretty much limited to that. But if you have another authority, I don't even think that.
Well,
Enforcement branch.
actually you do, and that's CMS. CMS actually investigates complaints of EMTALA violations, as well as the Health and Human Services Inspector, who, by the way, was just recently fired by Donald Trump. So you're enforcing EMTALA laws, and it's important that you understand their impact and politics with the patient presenting the ER based on a position that this administration has taken. Let me ask you a question.
Alright. So, we need to be informed. I know that seems like a kind of esoteric EMTALA, but it's a very important thing for us as citizens to understand, because this can impact our health and women we know's health when we think about making sure that people who are in leadership understand the laws that impact our health. If we have a heart attack, a stroke, we should get care. If we have a spontaneous abortion, we should get care. All right, so we're going to talk about the gag rule. This is another kind of administrative back and forth. It happens with every change from Republican or Democrat. And a gag rule really just is a restriction of provision and counseling for or advocacy for abortion. When you go from a conservative to a more liberal administration, it just bounces back and forth. So during the Biden administration, Title X clinics, which are family planning clinics that receive federal funds, could not refuse services for based on immigrant status. They could provide care to minors within the bounds of state laws, and they could counsel for referral to abortion services. And now we know that federal funds do not pay for abortions, but they could refer for them. Post-gag rule, so where we are now, is you can refuse services based on immigration status, and you can limit care to minors, and you can not provide abortion services or counsel for abortion care. So the work I've been doing has transcended administration, so I've worked with Title X clinics who've been under the gag and haven't been, and it does really change how they talk about abortion. So let's talk about kind of what Title X and Medicaid look like in Tennessee. So again, Title X funding is allocated to publicly funded clinics to provide family planning services. A requirement is to counsel on the full range of contraceptive methods and reproductive health services. So these provide these services at free and low cost to people in the state. So, kind of a little timeline. So in 2022, with the overturning of Roe, abortion became illegal in Tennessee. The Tennessee Department of Health then became in direct defiance of the Title X mandate under the Biden administration to counsel on all services. They said, we cannot counsel on abortion because we can't refer anybody in our state. It's not allowed. So then the Biden administration said, okay, then you can't have the money. Sorry, you have not fulfilled the requirements for this contract. We're taking the money from you. The state said, don't do that, please. And they went through the courts, and the courts agreed with the feds and said, no, that was part of the agreement you signed. You took the money, and then you said, I can't do this, so they took the money away. So currently, the feds had to find somebody to provide these services in Tennessee. And the new recipient in Tennessee is Converge. And as you can imagine, it's been a challenge because the health department has had this funds for decades and decades. So as you see on the left-hand side, these pink little dots are all the Title X Health Department locations. So we have a location in every county. In some counties, there's even more than one, and there's more populated ones. And then this is the Converge locations, and I wish they looked more similar, but you can see not every county has a clinic now. So with this change, we have lost quite a bit of access in our state, including in our own region. Part of your stance is around expansion. So Tennessee is one of 12 states that has not adopted expanded Medicaid. Our health commissioner was here just a couple weeks ago. He's very much in favor of it, which is a good thing. He's in favor of it. So we do have someone with the ear of the governor who is interested in it. There is movement on this. Fingers crossed, but we don't know what's happening at the national level with it. One success is that Tennessee does allow 12-month Medicaid cover for postpartum, and so that was approved in 2022. So previously, after a mother gave birth and she was on Medicaid, after 60 days, she rolled off. Now she's on it for 12 months. So that is a really big win, guys. So we do have some good news. And we're one of 12 at 50, so we need to get it. All right, I'm going to end on just showing you some Tennessee poll data. So we worked, our center worked with our buddies at in the Department of Sociology. They put out a Tennessee poll every 4 years on an election year. That is an opinion poll provided to provide citizens and governance of Tennessee with neutral, unbiased information on Tennessee's perceptions on issues that impact their health, education, and quality of life. They asked us to develop a module on reproductive health, and we said, yes, please. And so it is a representative sample that consists of 701 individual responses. And we're just going to highlight. And Ramsey asked us to show you by the grand division so you can kind of see how we look. Okay, so when we developed this, it was kind of in the summer when there was all this talk about IVF, if it should be legal. So we wanted to see what Tennessee had said. And no surprise, should IVF be legal? Yes. The vast majority of people believe IVF should be legal. But let's talk about our questions related to abortion. So our first question was, should a range of safe, effective, and affordable methods of abortion be available to women in their community? So should it be available? And just to help you orient, the bottom blue is strongly agree all the way to strongly disagree at the top. And so in East Tennessee, 55% of people either strongly agreed or agreed that it should be available. Middle Tennessee, 64, and West Tennessee, 64. So our region had the lowest who agreed, but it was over half. And our region agreed or strongly agreed that safe, effective, affordable methods of abortion should be available to women in their community. This is Tennessee. All right, and this is our perceptions. This is about what Tennesseans feel about having an abortion. Having an abortion is acceptable, may be acceptable depending on the circumstance, or it's never acceptable. In East Tennessee, 82% of people believe it's either acceptable or may be acceptable depending on the circumstance. 84 in Middle Tennessee and 86 in West Tennessee. So the 18%, the 14 to 18% represents what our law is. So our law in our state currently does not represent us. Okay? So we are not being represented by our law. And we thought this would be a good one to show you guys because this one asked, when you're voting for major offices, would you only vote for a candidate who shares your view on abortion, consider a candidate's position on abortion as just one of many factors, or it's not a major issue that I vote for? And so 30% of us in East Tennessee and Middle Tennessee say I would only vote for one that shares my views. While over half say it's one across the state, say it's one of many factors. So this is an issue that is important to all of us. Or a large 80 to 81 or 82% of us, this is an issue that we care about. So you're not alone if this is an issue you care about. Okay, these questions are a little bit different because we hear nationally some states are criminalizing providers. Some are trying to criminalize partners, criminalize all kinds of things. So we have two questions that we asked: should a woman be arrested or go to jail for having an abortion? And then we have a question about should a male partner who supports a woman. So when we look at this, again, it's strongly agree all the way to strongly disagree, or it depends. In East Tennessee, 13% of people agree that a woman, which is strongly agree or agree, should be arrested for having an abortion, which is the lowest level across Tennessee. So 16 in Middle Tennessee and 14 in West Tennessee. So the vast majority of us do not think women should be arrested for having an abortion. But interestingly, we think it's interesting, more people think that men should be arrested. So in East Tennessee, 18% of people think men should be arrested, 20 in Middle Tennessee, and 16. So when we look at it, they were one after the other. So we just thought this was an interesting question that I'll leave you on. That's still my last question, my last slide, and I will hand it over to my dear friend Maggie to talk about the work they do at A Step Ahead.
Hello, everyone. Hi. Thank you so much for having us. This is really an honor to be up here speaking with Dr. Beatty. Yeah, so thank you guys for being here too. Thank you for having us. My name is Maggie Wood. I'm the Executive Director of A Step Ahead Foundation Tri-Cities. We're a local nonprofit that works to help increase access to reproductive health care and help prevent unintended pregnancy. So it's really interesting and works kind of in a symbiotic way to get up here and speak right after Dr. Beatty, because a lot of what she just talked about in kind of like the graphs and the maps and the numbers and the research, we see kind of play out in the lives of the people who live here through what we do through our organization. So A Step Ahead Foundation Tri-Cities, we're one of 6 affiliates that cover the majority of the state of Tennessee, and we at Tri-Cities, we cover up into Southwest Virginia as well. We work to help remove barriers and prevent unintended pregnancy a couple different ways. One of those ways is that we provide free birth control. So we try to remove all barriers to access for reproductive health care, specifically for pregnancy prevention. So we work directly with clinics, telehealth clinics, in-person clinics, a mobile clinic, in order to provide free birth control. So if an individual wants to access free birth control or contraceptive counseling to help decide what sort of birth control they want to use, they get in touch with us or they get in touch with one of our clinic partners, and they go to the doctor, they go to the nurse practitioner, they have their appointments, they get whatever testing is needed, an STI test, pregnancy test, a PAP if they're due, and then if they decide they want a birth control method, they get that birth control method of choice. They go for their follow-up appointment if it's something that they need a follow-up appointment for. They go for the removal of the device if they chose a device method, and then all of the bills just come to us. So instead of the patient, instead of having to jump through hoops, the bills just come directly to us, and we pay for all costs associated with getting their birth control method of choice. We cover the vast majority of preventive birth control methods. So IUDs, intrauterine devices, there's a couple different types, Dr. Beatty mentioned those. IUDs and the next one on arm implant are the most effective in terms of like the actual stats, but there's a million reasons why someone might want to choose a birth control method. Medical history, personal preference, personal comfort, family history, whatever the case may be, if they want to get pregnant in the next year or 5 years or whatever. I mean, there's a million reasons why we make these choices. So we leave that choice up to the individual and their doctor. We cover the long-term methods, we cover short-term methods, and then we give out lots of condoms as well. So that, something for everyone, hopefully. Why do we need this here? We have high rates of unintended pregnancy in Northeast Tennessee. We're ranked pretty highly amongst teen pregnancy rates. It's like 24 point something teen births per 1,000 teenage women, versus the national average, which I think is closer to 16. It's closer to 16 teen births per 1,000. So we have pretty high rates. That varies county to county. But we see higher rates of unintended pregnancies in our communities that struggle with substance use disorder and opioid use disorder as well. We have very high rates of what's called neonatal abstinence syndrome, which is when baby's born dependent or exposed to a substance that mama took while she was pregnant. Baby is born, baby has to be weaned off of that substance. The vast majority, I think 82% of women who have a neonatal abstinence syndrome birth outcome share that it was an unintended pregnancy. Across the board, we also see higher rates of unintended pregnancy in marginalized communities as well. Statewide, 46% of our pregnancies, that's all across the state of Tennessee, metro, rural, and everything in between, are reported as unintended, and 54% of births are covered by Medicaid and TennCare. So you see that there's a great overlap in the unintended pregnancies, and then also folks who are in need of maybe state resources or federal resources or other resources. Let's see, what else was I going to talk about? We work in the school systems. We do a lot of education because we know that access to resources isn't the only way to affect change in our community. Educating the community on options, on medically accurate information is an incredibly powerful tool. I want to highlight specifically in the school systems what we do because that's most directly affected by changing policy. Because state standards are mandated, and what we teach as in what's called family life is we have to adhere really strictly to what the state says that we can teach. So when we go to the library, or when we go to an after-school program, or when we go to any program that is not part of the school system, we send home a permission slip 30 days in advance so parents can know that we're going to come in and we're going to teach. And they can opt their child in or they can opt their child out. We do this for any team that we work with, but we don't have to adhere to the same level of state standards. State standards require that we teach abstinence-focused or abstinence-emphasized family life education, which when you're working with 6th through 9th graders is a really age-appropriate choice as well. So it's great, hopefully, tools for our middle schoolers and our high schoolers to learn how to make safe choices before they are in a situation where they need to be making those choices. I will tell you, we've taught in the school systems for a number of years, and as far as I know, we've had one teen parent, one freshman parent in our classes. There could have been more, that was just all that we knew about. So we know on a practical level that teens are transitioning out of abstinence sooner than we might want as parents and guardians or grandparents or community members or community leaders. And that whenever we go, I will say anecdotally, we usually teach during gym. And so the gym teachers are usually really glad to see us because then they don't have to teach it. And then they also say thank you so much for being here because our students really benefit from this. They really need it because teenagers are curious and they usually have unfettered access to the internet, and so they know a lot of adult information, but they don't know how to keep themselves safe with that information. So we teach a wide range of subjects. 5th and 6th grade, we don't teach what you would think of as sex ed. We teach healthy boundary setting. We teach like issues like peer pressure. Like how do we deal with peer pressure? What are things we might feel pressured to do? We have worksheets that you take home that you're supposed to talk to your parent or guardian about what they felt pressured to do when they were in middle school or high school. And then we do a little like anatomy, puberty, hygiene. That's sometimes the most popular subject that the teachers get really excited about. And then teach everyone how to put deodorant on. So if you have a teen at home or a soon-to-be teen, that's a good conversation to have. Their teachers will thank you. And then when we get to 7th, 8th, and 9th, we start teaching more age-appropriate, state standard, in line with state standards curriculum about pregnancy prevention, sexually transmitted infections, consent, healthy relationships, healthy boundaries, teen dating violence prevention. Rates of teen dating violence are high. Rates of STI transmission amongst 16 to 24-year-olds are very high. We see really high rates of STI transmission. And there's a lot of factors for that. But one of the factors for that is information and education. Which birth control methods prevent against pregnancy prevention, which prevent against STI transmission. A lot of times these are things that aren't discussed, that people don't think about. Or people that aren't able to access that sort of information, or they hear misinformation from the people in their lives. They hear information like all birth control methods cause abortions, which is not the case, but that's just another kind of anecdotal thing that we've heard multiple times from multiple, not just teenagers, but adults in the community. This is what I've heard. Is this true? Is this not true? And then we also teach about human trafficking and online safety, because all of these subjects kind of fold together nicely. And when it comes to safety, how do we keep our bodies safe? Is really how we work with that. And again, when we do this, it's school board approved, and it's parent permission slips go home, and parents have access to all of this information. One law that I'll touch on a little bit later that has to do with changes in kind of access and ability to access information and reproductive health care is just this past summer, something called the Families' Rights and Responsibilities Act was passed, which means that teens can no longer access health care without parental consent, which sounds really great, right? We want parents and guardians to be involved in the health care of their children and those who they are guardians of. Absolutely 100%. But when I was at a SCAPI, I think is the acronym, I was at a adolescent pregnancy prevention meeting at a local health department, and the head of the health department was talking about, or someone there, I don't remember, I'm not going to say who it was because my memory's not serving me very well at the moment, but there was a lot of talk about what do we do in the case where the dad is the abuser? What do we do in the case of where the child is in foster care, and it has to be the parent who, like, the parent hasn't given up their rights yet, and so it has to be that parent, but that we can't get a hold of that parent, and this child needs an MMR booster, or this, something like that. This is not just about reproductive health care, but this is about all health care for minors. What do we do when the child is being sexually assaulted by their parent or their stepfather or their father or their grandfather? These were not what ifs. These happen. We see victims come through our services, and we're terrified at the ramifications of this specific law, because the way that this is going to pan out is really scary. It's really scary, and these are like real world cases where people's lives are going to be very, very different because of the laws that have been enacted. That sounds like they're ideal, right? Of course we would want parents and families involved in the health care of minors. And not only has this created a lot of inaccess, whenever a teen calls, we have to ask to coordinate with their parent or their guardian. We're no longer able to refer directly to a clinician. Not a 17 and under, excuse me. If you're a minor, you have to coordinate care directly through your parent or guardian. What was my point? It just left my brain.
Access
For teen
increased pregnancy.
I don't even remember what I was going to say. It's gone. Okay, maybe it'll come back. All right. Okay. So let's talk about Title 10 first, because Title 10 already happened. So Kate gave a really, really great breakdown of what Title 10 is. Title 10 is federal funding. We used to have it. It was over $7 million that the state would spend of this federal funding every year to provide low or no cost family planning resources to folks who couldn't afford it. So if you were someone, and you would go in and you would self-disclose. So there weren't a bunch of hoops that you had to jump through. You would go to the health department. The Tennessee health departments were the ones who were the recipients of this funding. You would go to the health department, say you were a woman, say you were a 40-year-old woman who was a victim of sexual assault in her marriage, and she didn't want her husband to know that she was accessing birth control because she couldn't handle another pregnancy in her marriage where she was a victim of sexual assault. And she could go and she could say, I need to access for free these resources, and she would be able to access them for free or for a very affordable rate in a safe way where her husband wouldn't get a bill, right, or an explanation of benefits from their shared insurance. So these are, important resources that all sorts of people access for all sorts of different reasons. You would access those at the health department. And the great thing about the health departments all the way across the state is, as Kate's map showed, there was one in every county. There was at least one in every county. And even if that one in every county only did family planning twice a month, which some of them do, there was still one in every county. You weren't having to travel 2-3 hours away. you could access the one in your county. That funding was lost in 2023. I say 2024, that's incorrect. It was in 2023. And it was replaced with state funding. So the governor said, I'm going to replace this with state funding. And we all breathed a sigh of relief until we found out that that state funding was held to different sort of laws and requirements than the federal funding. So in order to access that state funding, that family planning resource at the health department, where people had been accessing, safe and confidential and affordable reproductive health care and, cervical cancer screening and mammograms, like the list goes on, it's not just birth control. They now had to provide proof of documentation or residency in order to access these resources. So the state health department never officially released a percentage of how many people were now without access, but unofficially off the books, we have heard it was around 50%. So around 50% of people accessing this resource at the health department were folks who could not provide proof of documentation or residency. So all of a sudden, thousands and thousands of Tennesseans were one day, boom, went to the health department and they said, I'm sorry, I can't serve you anymore. And we all know when proof of documentation or residency is required, there are all sorts of more scary things that could potentially come from being in a situation where you are required to provide proof of documentation or residency, right? So this is bigger than just not being able to get a pill prescription or even a cervical cancer test. Okay, so all of a sudden, it was like the next day, all across East Tennessee specifically, we, a step ahead, saw drastic increases in monolingual Spanish-speaking clients reaching out for clinic services. We do not track documentation. The only thing that we track is through a self-disclosure form, and you don't have to even fill it all out if you don't want to, because we like to remain pretty accessible. But we saw 60, so for example, just in 2025, for the month of January, 67% of our clinic clients are monolingual Spanish-speaking, so they fill out their disclosure form in Spanish. Year over year, we saw a 60% increase in demand for clinic services. So from 22 to 23, we saw a huge percentage increase because I think around that time we started offering less expensive methods like the pill, the match, and the ring. We only saw a 25% increase in clinic costs, but it was still a significant increase. And as a small 5-person nonprofit, it feels a little David and Goliath-y when we're all of a sudden being the ones who are trying to fill this giant void of millions of dollars of thousands of people who are now without access to important, necessary health care. Okay. Upcoming policy and legislation. Okay, so nothing is currently proposed to restrict contraceptive access on a state level. So there's a fetal personhood interpretation that might affect contraception, which means that people like to argue about when life begins. We like to just listen to doctors and scientists when they say that these methods are preventive and these methods aren't. And so we cover these methods that are preventive, the pill, patch, the ring, the birth control shot, Depo-Provera, the arm implants, and the IUDs. When Roe v. Wade fell and Justice Thomas made a lot of comments about other cases that needed to be re-looked at, one of those was the right to contraception, and that threw a lot of concern and fear and confusion into the mix of whether or not these resources were going to continue to be made available. As of right now, we all have a right to contraception, but there are rumblings, and it seems and feels, and we hear that it's something that will unfortunately continue to be kind of chipped away at because of conversations about like when life begins. So if it becomes the law of the land that life begins at conception, then it's easier to make an argument that IUDs are abortive. Yeah.
Do you depend upon any federal or state grants or monies in any form in order to provide?
We don't currently. A step ahead Tri-Cities. does not currently. We work with Valid Health, we work with other family foundations, we do fundraisers, that sort of thing. We did just apply, there's a state health department grant that has to do with rural resiliency that we just applied for, but we'll see if we get it. We'll see, probably not. But there are definitely opportunities on the state level that fund reproductive health care and preventive birth control. There absolutely are. But then in direct opposite, in direct juxtaposition to that, there are state legislators saying that they have concerns about contraception in general. So this was the first we've seen of that. Representative Camper didn't say that she did. She said that lawmakers pushed back against this specific bill that I think had to do with IVF. I could be wrong, don't quote me on that, because of concerns about contraception in general. And so when we read that, that was a little bit of an alarm bell that went off. I don't know what those concerns are, but it will be interesting to see and track what comes out of this in terms of policy over the next couple years, because apparently some of our legislators have concerns about contraception in general. There are legislators who are making an effort to define preventive birth control as not abortive with policy at the state level, but none of them have made it far at all. So there are things to support. There are things to track. Usually none of them have gone anywhere, but there are attempts to make these things clear, right? That preventive birth control is safe and not abortive and all sorts of good stuff. Okay, there's really fun stuff coming out, like Mississippi proposed legislation to make ejaculating without consent a felony. So they want to make it that you can't ejaculate without intent to impregnate someone, which that's never going to pass, right? I mean, it sounds like satire. I mean, doesn't it? It really, but these are things that people are thinking are, and the thing that it shows that's scary is that there's this push toward intercourse only for procreation, which is so Gilead wild, right? I mean, it's just terrifying. What the research shows is that easy access, barrier-free access to preventive care across the board, right? We're not just talking about birth control, but if we want to talk about all preventive care, but specifically reproductive health care, is builds better, healthier communities. It allows families to be more educated and economically stable, and it saves money and lives. Yes, 100%. These are the things that we know. This, ejaculating without intent to impregnate, is on a different planet. These are the things that we know. We know that prevention works, we know that funding prevention works, and we know that families are healthy and alive when we're able and economically stable and educated to the degree that they want to be educated, when we provide communities and individuals with the ability to plan their pregnancies the way that they want to, when they want to, how they want to. All right, let's see what else I said. Okay. I want to highlight one more thing, which is that map. It's far back that Dr. Beatty was talking about. This map looks this way. This map looks this way because of ETSU and our health departments and Valid Health. I know that there's a lot of the way that we see this map. Johnson County up in the corner is dark purple, which is incredible. That's because they have a health department that offers all methods, and that's because they have an ETSU nurse run clinic that offers all methods. So if we're talking about ways that we can, and then if you look at this map, where is it? Oh, here we go. There's no Title X clinic now in Johnson County. Now there's a health department where if you're undocumented, you cannot get access to resources. And there's an ETSU nurse run clinic that we partner with that you can get free birth control if you would like, which is great. But because of this loss, you see how in our region there is just a drastic loss of resources. And it's not just our region. It's everywhere that's rural, right? It's everywhere that's rural. there's huge counties in outside of Chattanooga that there are no OB providers now. There are none. So it's scary, and and we know that this causes lives and or costs us lives. And I am so honored to be here today and also give the microphone over to my dear friend Rebecca. Is there a slide? Personal experience. Here we go. So